Welcome to the deep dive. Imagine your body as like a finely tuned orchestra, every instrument playing its part perfectly, led by this brilliant conductor. But what happens when that conductor, in this case, your kidneys, starts to go a bit off key? Today, we're diving into the complex, but incredibly vital world of kidney disease. It's an area filled with medical terms, kind of dense sometimes, but we're here to cut through that noise, give you a clear, impactful understanding.
Precisely. Our mission today is really to demystify the essential parts of kidney function and, well, dysfunction. We'll focus on how these crucial balances go wrong
Okay.
and the incredible medical interventions available when the body's own systems falter. We're pulling from a detailed source, aiming to give you a clear understanding of everything from your blood gases to the real nuts and bolts of dialysis.
So you'll walk away with a much clearer picture of what kidneys do, what happens when they struggle, and, the cutting edge ways we support them. You'll get the what, but also hopefully really grasp the why it matters so much.
Okay, let's unpack this. First, let's set the stage. The basics of how our bodies keep things in balance. Specifically, let's talk about ABGs, your arterial blood gases. Pretty fundamental stuff here.
Absolutely fundamental. Think of ABGs as a snapshot, a real-time look at your body's acid-base balance. We're mainly looking at three key things. pH, which ideally sits between 7.35 and 7.45, that's acidity or alkalinity.
Right.
Then CO2, usually 35-45, which is managed mostly by your lungs. And HCO3, or bicarbonate, normally 22-28. And that's where the kidneys really come in. When kidneys are involved, we're watching closely for shifts towards metabolic acidosis or metabolic alkalosis. Big red flags.
That's a good breakdown. Now, you mentioned the body tries to adapt when these numbers, go sideways. How well does that actually work? Does it sometimes just mask the real problem? That's a really sharp question. And it's crucial. In acute, sudden situations, the ABG will be uncompensated. Your pH will be clearly off. And usually either the CO2 or the HCO3 will still be normal. The body just hasn't had time to react fully.
Okay.
But in chronic conditions, the body tries to compensate. So your pH might look normal or nearly normal.
Tricky.
Very tricky. Even though both CO2 and HCO3 are abnormal, it's the body trying hard to maintain balance, even under chronic stress. It shows how long-term issues can kind of hide. A quick tip for interpreting that compensated pH: if it's closer to 7.35, think acidosis. Closer to 7.45, think alkalosis.
That's a great aha moment, seeing the body struggle behind a seemingly okay number. So how do these specific ABG issues link directly to the kidneys failing?
Well, very directly. We often see metabolic acidosis in kidney failure,
Yeah.
especially in what's called the oliguric stage of acute kidney injury.
Oliguric meaning?
Meaning urine output drops way down.
Yeah.
Makes sense, right? Kidneys aren't getting rid of the acid. Conversely, metabolic alkalosis can sometimes pop up in the diuresis stage, maybe when kidney function starts recovering unevenly and they dump too much fluid and acid. And this whole acid-base thing. It's tightly linked to the electrolyte imbalances that the kidneys struggle with.
Right. The ABGs give us the overview, but the electrolytes are the specific players really causing trouble when the kidneys struggle. So what are the main electrolyte imbalances we need to watch out for?
For the kidneys, the really critical ones are fluid volume overload, hyperkalemia, there's too much potassium,
Okay.
hypocalcemia, low calcium, and hyperphosphatemia, which is too much phosphorus. These aren't just separate issues. They're the direct fallout when kidney function is compromised. Like instruments in the orchestra just totally going off key.
Let's start with fluid volume overload. That one seems pretty visible, something you can often see and feel directly. What are the telltale signs someone might be dealing with this?
Yeah, it's a major one. The body just can't get rid of excess fluid. So you'll see things like a high heart rate, high blood pressure, shortness of breath. Definitely. Sure. You might hear crackles in the lungs if you listen with a stethoscope. Sometimes even pink or blood-tinged sputum in severe cases. And a really striking sign, though less common, is skin weeping. Yellowish fluid literally oozing from the skin.
Wow.
Because it has nowhere else to go.
Right.
Plus, you see significant weight gain, swelling everywhere, edema and ascites.
Ascites being
Fluid buildup in the abdomen. You can sometimes tell by tapping the belly, percussion. It gives a loud, high-pitched tympanic sound.
That image of skin weeping is powerful. Really paints a picture of the body overwhelmed. So what do we do? What are the interventions when someone's got this much fluid overload?
Well, first steps are usually restricting fluids and sodium intake. Remember, water follows sodium.
Right.
For acute situations, we often use loop diuretics, things like Lasix or furosemide. They work fast. For more chronic management, maybe spironolactone.
Yeah.
That's a potassium-sparing diuretic, so you have to watch potassium levels.
Okay.
If those aren't cutting it, we might bring out mannitol. That's an osmotic diuretic. Works
Yeah.
differently.
Mannitol. Sounds potent. What's unique about it? How does it help when the fluid seems trapped everywhere?
It's unique because it pulls fluid from what we call the third space,
Third space meaning.
areas outside the blood vessels where fluid shouldn't really be accumulating in large amounts, like the abdomen and ascites, or the lungs, sometimes even the brain. Mannitol drags that fluid back into the bloodstream so the kidneys, if they have some function left, can hopefully excrete it.
Interesting mechanism.
It is. One practical note, mannitol can actually crystallize in the vial, especially if it gets cold.
Oh, really?
Yeah, so it often needs to be warmed gently, maybe in warm water, and drawn up with a special filtered needle to catch any crystals. And if diuretics and everything else still aren't enough, well then dialysis is really the next step. Sometimes doctors might give albumin first, intravenously, to help pull even more fluid into the vessels right before dialysis removes it.
Okay, so managing fluid is critical. But you mentioned potassium hyperkalemia. That sounds less visible, but potentially more immediately dangerous, especially for the heart.
Absolutely. High potassium, hyperkalemia is extremely dangerous. It can cause life-threatening heart rhythm problems, cardiac dysrhythmias. You see specific changes on an EKG, like wide QRS complexes, maybe prolonged PR intervals, or tall peaked T waves.
Scary stuff.
It is. Patients might have a really fast heart rate, tachycardia, or a slow one, bradycardia, or even severe rhythms like VTach or AFib. Other signs can include increased deep tendon reflexes, muscle weakness, sometimes confusion or altered mental status.
Given how dangerous those heart issues are, what are the key ways to bring that potassium down quickly and safely?
We've got a few important tools.
Mhm.
One is a medication called sodium polystyrene sulfonate, brand name Kayexalate. Given orally or sometimes rectally, it basically binds potassium in the gut and makes you excrete it through diarrhea.
Effective, but maybe not pleasant.
Not always pleasant, no.
Yeah.
There's a newer one, Lokelma, sodium zirconium cyclosilicate. Also binds potassium, but the powder you mix and drink, and it doesn't cause diarrhea. Needs to be stirred and drunk quickly, though. We also use insulin, regular insulin, along with dextrose. The insulin pushes potassium out of the blood and into the cells
And the dextrose is?
to prevent blood sugar from dropping too low, because insulin does that too. So you give them together. Calcium gluconate is another important one. It doesn't actually lower potassium levels.
Oh.
No, but it stabilizes the heart muscle, makes it less likely to go into those dangerous rhythms, buys you time while other treatments work.
Protects the heart directly.
Exactly. And of course, you'd stop any potassium-sparing diuretics like that spironolactone we mentioned earlier.
Makes sense. Okay, that covers potassium. Now, you mentioned calcium and phosphorus often go together, but in opposite directions. Hypocalcemia and hyperphosphatemia, what's the connection there?
Yeah, they have this really fascinating inverse relationship, and the kidneys are key regulators for both. When kidney function declines, they often can't get rid of phosphorus effectively, so phosphorus levels go up. That's hyperphosphatemia. And when phosphorus goes up, it tends to bind with calcium in the blood, effectively lowering the amount of free active calcium. So you get hypocalcemia, low calcium. It really shows how one organ failing throws off this delicate chemical dance.
And what are the signs of low calcium? You mentioned tetany.
Yes, tetany is a big one. Includes tingling, numbness, especially around the mouth or in the fingers and toes, muscle cramps or spasms. There are specific clinical signs doctors look for too, like Schwastek's sign. You tap on the facial nerve near the cheek and the facial muscles twitch. And Trousseau's sign, you inflate a blood pressure cuff on the arm and the hand and wrist go into this characteristic spasm.
Wow, quite specific.
They are. Severe low calcium can even cause laryngospasms where the airway tightens up. That's life-threatening. And chronically low calcium contributes to bone problems, increased risk of fractures, bone pain, because the body's trying to pull calcium from the bones.
So given they're linked, how do you tackle both high phosphorus and low calcium?
Well, managing phosphorus often involves diet first. Cutting back on dark sodas, processed foods, dairy, they're often high in phosphates.
Okay.
We also use phosphate binders. These are medications taken with meals right after eating usually. They bind to the phosphorus in the food you just ate, preventing it from being absorbed into the bloodstream.
Clever.
Yeah. And because of the bone risk, fall precautions are really important for these patients. For the low calcium side, we often give vitamin D supplements. Active vitamin D helps the gut absorb more calcium.
Right.
And calcium supplements themselves, like calcium carbonate orally. If it's severe or they have symptoms like tetany, then IV calcium gluconate might be needed. But a critical point about IV calcium gluconate or calcium chloride.
Yes.
It's a vesicant, meaning if it leaks out of the vein into the surrounding tissue, it can cause serious tissue damage, even necrosis.
Oh, that's serious.
Very. So it has to be diluted properly, given slowly, ideally through a large vein, like in the AC, the crook of the elbow, with a good-sized IV, maybe an 18 gauge, or even better, through a central line if the patient has one. Close monitoring is essential.
Got it. Critical safety point there. Okay, so we've managed fluids, potassium, calcium, phosphorus. But sometimes, despite all that, the kidneys just can't keep up. That's when the conversation turns to dialysis, right? The
Yeah.
machine's taking over the job.
Exactly. When medical management isn't enough to control the fluid overload, the high potassium, the severe acidosis, or the symptoms of waste buildup, dialysis becomes necessary.
And you mentioned wet weight and dry weight earlier. How does that factor into dialysis planning?
Yeah, that's fundamental for hemodialysis especially. Wet weight is the patient's weight before the dialysis session, including all the excess fluid they've accumulated. Dry weight is the target weight after dialysis, what we estimate their weight would be without that excess fluid.
So the goal is to remove the difference.
Pretty much. The difference between wet and dry weight tells the dialysis team how much fluid needs to be pulled off during that treatment session to get them back to their target weight.
Okay, let's talk hemodialysis then. It's the most common, you said about 90% of patients. What actually happens during a session?
Right, hemodialysis is the workhorse. Basically, blood is pulled from the patient's body through a special access point.
We'll get to those accesses in a minute.
Yeah, the blood goes into tubing and passes through the dialyzer. That's the artificial kidney. Inside the dialyzer are thousands of tiny hollow fibers made of a semi-permeable membrane. Blood flows to the fibers. And on the outside of these fibers, a special fluid called dialysate flows in the opposite direction.
Okay, the dialysate, what's in that?
Dialysate is carefully prepared fluid. It has electrolytes like potassium, sodium, calcium set at normal, healthy levels. It also has bicarbonate to help correct acidosis and glucose.
So that semi-permeable membrane is where the action is. How does it clean the blood?
Exactly. It works mainly by diffusion. Remember, high concentration moves to low concentration.
Right.
So if the patient's blood has high potassium, say a level of 8, and the dialysate flowing around the fibers has a normal potassium level, say 4, the excess potassium from the blood will diffuse across the membrane into the dialysate fluid.
Moving down the concentration gradient.
Precisely. Same thing happens with waste products like urea and creatinine, high in the blood, low or 0 in the dialysate. So they move out. Excess fluid is removed too, using pressure gradients, a process called ultrafiltration. And this whole process repeats, cycling the patient's blood through the dialyzer for usually 3 to 4 hours, typically 3 times a week.
That's a significant time commitment, but clearly life-saving. You mentioned needing special access points for this repeated blood withdrawal and return. What are the options?
Access is absolutely key for hemodialysis. There are several types, kind of a hierarchy. For temporary, immediate access, often in the hospital or emergency, there's a Voscath. It's a large central venous catheter, usually put into the subclavian, jugular, or sometimes the femoral vein.
Okay, temporary.
Yeah, maybe for a few weeks. Can be put in at the bedside, but has risks like infection or collapsing a lung, pneumothorax. Then there's a perm cath, also a central line, but it's tunneled under the skin for part of its length before entering the vein.
How does tunneling help?
It helps anchor it better and creates a barrier, reducing the infection risk compared to a fast cath. So it can potentially last longer, maybe up to a year. Still needs sterile care, though.
Okay, moving towards more permanent options.
Right. The next best is usually an AV graft. AV stands for arteriovenous. Here, a surgeon connects an artery and a vein in the arm, usually using a synthetic tube, the graft material. This creates a high-flow circuit under the skin. Dialysis needles are then inserted directly into this graft for treatment.
And the best option?
The gold standard, the best long-term option if possible, is an AV fistula. This involves directly connecting an artery to a vein, again, usually in the arm, without any artificial material.
Just connecting the patient's own vessels.
Exactly. The high pressure from the artery flows into the vein, causing the vein to enlarge and strengthen over weeks or months. This process is called maturation. Once mature, this fistula provides a durable, natural access point for dialysis needles that can last for many years, even decades, with the lowest risk of infection or clotting compared to grafts or catheters.
I've heard people talk about feeling a thrill or hearing a bruit over these fistulas and grafts. What are those? Why are they important?
Yes. Thrill and bruit. They are vital signs that the access is working properly. Essential checks. A thrill is a vibration you can feel when you gently place your fingers over the fistula or graft. Feels kind of like a cat purring, maybe a bit stronger. A bruit is the sound you can hear with a stethoscope over the access. It's a whooshing or buzzing sound. Both the thrill and the bruit are caused by the rapid, turbulent blood flow through the access. If they're present, it means blood is flowing well and the access is patent or open.
So, feeling for the thrill and listening for the bruit is a daily check.
Absolutely. Patients are taught to check it. Nurses check it before every dialysis treatment. If the thrill or bruit disappears, it could mean the access is clotted off, which is an emergency. And speaking of protecting these accesses, especially grafts and fistulas, there are critical rules.
Like what?
No 5E sticks, no blood draws, and absolutely no blood pressure measurements on the arm with the fistula or graft. Ever.
Wow, lifelong precaution.
Lifelong. You need to protect that arm from trauma, avoid tight clothing or jewelry, don't sleep on that arm, don't carry heavy things that might compress it. That access is literally their lifeline.
Makes sense. Now, briefly, you mentioned CRRT earlier. Continuous renal replacement therapy. How does that differ from standard hemodialysis?
Right, CRRT. It's basically a form of hemodialysis, but it's done continuously, 204/7, usually in the intensive care unit. It's a much gentler, low and slow process. It removes fluid and waste products much more gradually than the standard 3-4 hour session.
Why do that?
It's for patients who are critically ill, maybe hemodynamically unstable, meaning their blood pressure is very fragile. They might not tolerate the rapid fluid shifts and blood pressure changes that can happen with conventional hemodialysis. CRT is much gentler on their system.
Okay, so specialized for the sickest patients. And finally, there's peritoneal dialysis. Sounds completely different.
It is quite different in its mechanics. Only about 8% of dialysis patients use it. They have to meet certain criteria. Instead of using an artificial dialyzer, peritoneal dialysis, or PD, uses the patient's own peritoneal membrane,
Which is
the natural lining of the abdominal cavity. It acts as the semi-permeable membrane. A soft, flexible tube called a Tenkoff catheter is surgically placed into the abdomen. It looks a bit like a feeding tube, maybe. Through this catheter, dialysis fluid, the dialysate, is infused into the peritoneal cavity, the space within the abdomen.
So the fluid goes inside the belly.
Exactly. It dwells there for a set period, usually several hours. During this dwell time, waste products and excess fluid from the blood vessels supplying the peritoneum diffuse into the dialysate. Then the fluid, now containing the waste, is drained out through the same catheter. This process of filling, dwelling, and draining is called an exchange.
And how often is this done?
Typically, exchanges are done multiple times a day, maybe 4 to 6 times, depending on the patient's needs. Or sometimes it's done overnight using an automated machine called a cycler while the patient sleeps. A big advantage is that it can be done at home by the patient themselves or a caregiver after training.
That sounds like a huge plus, being able to do it at home, more flexibility.
It is. It offers more lifestyle freedom, fewer trips to a dialysis center, often less strict dietary and fluid restrictions compared to hemodialysis. It's a more continuous, gentle form of dialysis, kind of mimicking steady urination.
Sounds appealing. What are the downsides, though? The trade-offs?
The biggest risk with PD is infection, specifically peritonitis. That's an infection of the peritoneal lining itself. Potentially very serious. It requires prompt antibiotic treatment, sometimes hospitalization, and can lead to scarring that makes PD no longer possible. So maintaining strict sterile technique during every single exchange is absolutely critical. It's a huge responsibility for the patient.
I can imagine.
Other potential issues include less precise fluid balance control sometimes compared to hemodialysis, maybe body image concerns about the catheter, occasional hernias, or even constipation or respiratory issues if the fluid volume in the abdomen is large.
So a lot to weigh up when choosing between hemodialysis and peritoneal dialysis if both are options.
Definitely. It depends on the patient's medical condition, lifestyle, support system, personal preference, and their ability and willingness to manage the treatment safely at home for PD.
So reflecting on all this, from the subtle shifts in blood chemistry to these major technological interventions, what's the big picture?
You know, what's really fascinating here is the sheer ingenuity involved, how medical science has found ways to support or even replicate the function of such a vital organ. From decoding those tiny changes in pH and electrolytes to developing these complex dialysis machines and sophisticated access methods, it represents layers upon layers of intervention, all designed not just for survival, but to restore some measure of balance and quality of life. It really highlights medicine's ability to step in when that internal conductor, the kidney, needs help keeping the whole orchestra playing.
It really does. So you've taken this deep dive with us into the intricate world of kidney disease. We've looked at the critical roles of ABGs and electrolytes, how to recognize those signs of imbalance, some subtle, some dramatic. And we've graphed the incredible technologies behind dialysis that literally keep people alive. It's a powerful reminder, isn't it? How intricately our bodies work and just how vital those kidneys are for maintaining that delicate internal harmony. So, what does this all mean for you listening?
Yeah, that really raises the important question, doesn't it? Now that you understand a bit more about how kidney disease can show up and the different ways it's managed, how might this change your perspective? Maybe on your own health, on preventative measures, or just on the incredible resilience of the human body, even when facing such profound challenges. What part of your own internal orchestra, maybe, needs a little more attention today?